The topic I'm going to cover is how to unravel the enigma of negative dysphotopsia. There are two kinds of light. The glow that illuminates also may cause glare that obscures. Imagine you have just performed a successful uncomplicated cataract surgery and given vision of 6 by 6 to the patient, and you are ready to be congratulated. But instead, when your patient starts screaming, "Doc, I hate these unwanted images that you have given me," this is not what you wanted to hear as a successful surgeon. So, what is dysphotopsia? These are undesired optical images associated with the otherwise uncomplicated cataract surgery and has become number one problem following successful cataract surgery. Patients are incredibly unhappy, move from one ophthalmologist, it's moving on its own. They move from one ophthalmologist chamber to other, and when they are told that surgery is perfect, this makes them more angry. So, although this term is gaining acceptance, it's a misnomer. Why? Because photopsias are visual perceptions that arise in the absence of light stimuli, and the visual disturbance of dysphotopsia do not occur in the absence of light stimuli. In literature, terms such as entoptic phenomena, photic phenomena have been used, but the term dysphotopsia was used for the first time in June 2000. It is really a riddle wrapped in a mystery inside an enigma because it's an enigma of cause, prevention, and treatment. Both surgeons and patients are equally frustrated, and when the surgeons tell their patients that it will go away with time, it does not always turn out to be true. So, how upset are these patients? Some of them are so upset that they have filed lawsuits against ophthalmology. It's jumping on its own. They have filed lawsuits against ophthalmologists and lens manufacturers, and now there is even a website for these patients who have really collected together. So there are two major categories. We'll straight away jump to those on the bottom hand of the slide. Those arising from the IOL edge, that is the culprit. Edge reflections are called positive dysphotopsia, and edge shadows are called negative dysphotopsia. We wanted some desirable traits in foldable lenses that have led to undesirable optical phenomena. We wanted a thin lens to go through a small incision, it acts like a mirror. We wanted square edge to decrease PCO, but it has internal reflections. The hydrophobic lenses are preferred by one and all because because of low PCO rates, but because of low anterior curvature and high refractive index, they cause more dysphotopsia. Truncation, bitruncation, all have mirror-like effects. So these are the various desirable traits we wanted. We wanted square edge, we wanted truncated edge, but now they are leading to problems because of various undesirable optical phenomena. So this was first reported in 2000 by James Davison, who likened this temporal darkness to horse blindness because it occurs in the temporal field of vision. Commonest type, least understood, more debilitating, and unfortunately it is associated only with perfect surgery, good surgeons, good IOLs. It does not occur with sulcus IOLs, it does not occur with anterior chamber IOLs, and incidence with PMMA IOLs is also less. It's an enigmatic penumbra. It's a sickle-shaped dark shadow or crescent that gives the impression of a shade in the temporal peripheral region of the patient's vision. And one author has very rightly described, you need to do a military salute on the temporal side to disturb that light which is causing these undesirable optical phenomena. Holiday has very nicely described the optics of this. There are type 1, type 2 and type 3 shadows, and this is type 3 shadows. Why it occurs, I'll come in the subsequent slides. The first explanation that was given was that temporal rays of light come from the temporal field of vision. They go through the nasal pupil, they strike the nasal edge of the IOL, and this light is reflected back temporally. And since now there is no rays of light to be refracted, there is shadow in the nasal region, but since it is caused by temporal rays of light, it causes temporal shadow in the temporal field of vision. So this is one. Second explanation given was, as you see on the topmost slide, I don't have a pointer please. There is rays of light which again goes from temporal field of vision. It grazes the anterior surface of the IOL, and the other ray of light is refracted from the anterior edge of the IOL. So there is a shadow between these two, and this causes this gap is the result of discontinuity between the light passing between the iris and the IOL and the light refracted by the IOL. So this was experimental model which was done with ray tracing. On the top hand side, you find that it is the phakic eye. Why? Because the crystalline lens has a larger diameter. And all these rays of light coming at various angles, they are refracted and into a point focus. But in the bottom portion, you find in the pseudophakic eye, the IOL diameter is not that much, and so there is a aphakic area, and this aphakic area leads to a gap between the rays of light which are unrefracted and refracted. And how much is that? This is another ray tracing diagram where they find that 30-degree rays of light which are coming at 30 degrees, 60 degrees, 90 degrees, they are all brought to a point focus. But see these rays of light which are coming at 90 degrees, they are not illuminate. It illuminates two different retinal regions, and the gap between two different retinal regions leads to a shadow. And why it occurs with the sharp edge and not with the round edge, this again has been very nicely explained by the optics by Holiday, where they find that the rays of light which are refracted at the bottom edge are refracted much more posteriorly than the rays of light which are refracted from the posterior surface. Again, there is a gap between these two refracted rays, and it has found that the maximum refracting angle from rays refracted by intraocular lens was 85.7 and the minimum angle was 88.3 degree. So this difference of 2.6 degree in the extreme temporal field will cause the shadow to appear. So what are the optical factors which are required for development of negative dysphotopsia? They can be classified as primary and secondary factors. Primary factor is smaller pupil. Distance behind the pupil, which is much more now, and it is calculated to be 0.06 to 1.2 millimeter for acrylic and 0.06 to 0.6 for silicon. Mind you, the distance required for silicon is much less. Sharp edge design, functional nasal retina that extends much more anteriorly, and there are of course secondary factors also like short axial length, high IOL power, high index of refraction of optic material as occurs with the Alcon lenses, small IOL diameter, large angle alpha, nasal location of the pupil relative to the eye's optical axis. Another important factor is transparent status of the peripheral nasal capsule, because some of the authors think that it is the shadow of the peripheral nasal capsule projected onto the nasal peripheral retina. Then non-inferotemporal orientation of the optic haptic junction. If you place the optic haptic junction vertically, you are more prone to get it. Why this dark shadow of the light occurs only temporally and not nasally? Because light coming in nasally is tempered by the nose, eyebrow and cheek, and second factor is nasal retina may extend further anteriorly than the temporal retina. So these are the diagrams which have been drawn by the patients themselves. This is temporal sickle shaped shadow, and another author has published that they can be, this was the questionnaire which was given to the patient, and they say it can be in the form of black edge, grey crescent, black crescent, blurred edge, or just a small black corner which is sickle shaped. What is the incidence? Incidence in the immediate post-operative period is very high. It's as much as 20%, but after 6 months it decreases, and after 2 years it becomes just 2%. And incidentally, negative dysphotopsia tends to occur more commonly in the left eye and more commonly in the females. So these are different types. Transient dysphotopsia resolves in 2 weeks. Nothing to worry about, because this is due to the hydration of the temporal clear corneal incision that resolves on its own. Temporary resolves in 6 to 12 months, and this is again because of the optics which I have told you. It is the persistent variety which consists of lingering cases that annoys the patient and perplexes the surgeon. So it is, again I'll repeat, associated with well-centered in the back PC IOLs, does not happen with poorly centered IOLs, does not happen with sulcus PC IOLs or AC IOLs, occurs more frequently with higher index of refraction, less incidence with 3-piece silicon IOLs, increases with bright light, stimulated by temporal light source which and goes away when the light is removed. Symptoms present early, usually resolved by 6 months, and in most cases by 2 years. Despite seemingly similar anatomical features, it may not occur bilaterally in the same patient. Dilate the pupil, problem resolves. Constrict the pupil, problem worsens. Since no medical therapy seems to work, surgical management may be required in these persistent type of negative dysphotopsia. And what are the surgical management which has been described? Number one, remove this nasal annulus of anterior capsule, which may be casting shadow. Second is place shoulders of haptic of IOL horizontally. Third is reverse optic capture, piggyback IOL implantation, and there are very novel anti-dysphotopic IOLs popularized by Masket. Then there is a BIL, bag in the lens, by Mary Jo Tessignon, iris suture fixation, supplementary sulcoflex, or in the cases which are not resolved by any of these measures, lens exchange may be required. But of these measures, the most common treatment which is advocated and is successful is reverse optic capture and the piggyback IOL implantation. This proves that in majority of the cases, this is maybe because of the shadow of the anterior capsule edge. So you just need to yag the nasal annulus of the anterior capsule as shown here. And in a lot of these patients, because it's a simple non-invasive procedure, and if patient resolves, you can rest assured that the patient will be happy later on. Single piece, we can place the shoulders of the haptics horizontally. How it helps is in single piece IOL, this optic haptic junction, this behaves as extension of the optic, and rays of light may be not going into the aphakic area, it may be striking the nasal edge and may be refracted. So this light will be scattered and it will bleed through the edge of the lens and fill in the area of the shadow. So negative dysphotopsia may not occur. So we should try to place this either horizontally or the haptics should be inferotemporally. But it has been found that this strategy is relevant mainly for transient negative dysphotopsia symptom, and because later on it was found when a study was done, difference in the incidence of ND based on haptic orientation did not exist after 1 week or 1 month. Reverse optic capture, popularized by Dr. Basket, and what he does is it teases the IOL of the anterior capsule. So the optic is brought in front of the anterior capsule both nasally and temporally. And if the patient has given problem of negative dysphotopsia in one eye, then you may practice primary reverse optic capture in the second eye of this patient. So this is how it is done. Fill the eye with viscoelastic, tease of the anterior capsule, and bring the optic first nasally and then temporally. Now you have the haptics are in the back, but the nasal and temporal edge of the optic is in front of the nasal and temporal rim of the anterior capsule. Piggyback IOL, how does it help? It decreases the distance between the iris and the IOL. And secondly, it also covers the anterior capsule and the IOL edge. So indications are symptomatic patients of negative dysphotopsia, but then there are requirements that the first surgery should have been uncomplicated, no evidence of zonulopathy, and iris should be free of defects. A new IOLs has been introduced. This is by LensTech, which was being discussed earlier in one of the presentations. And how does it help? It is not a round optic. It is horizontally oval optic, where it is larger in the horizontal direction 6.5 millimeter and shorter in the vertical axis. This is Masket anti-dysphotopic IOL, and what they have is on the edge of the optic there is a groove into which rests the anterior capsule. So there is no anterior capsule annulus to cast shadow, and this is also one of the concepts that is being introduced. Bag in the lens IOL, difficult to practice, but it's a very innovative concept which was popularized by Mary Jo Tessignon from Belgium. And instead of IOL in the back, both anterior and posterior capsular axis rest on the IOL margin. This is from our India. Prakhyat Roop has given this presentation where the optical center is decentered by 0.3 millimeter and horizontal axis is more than the vertical axis. So if symptoms do not resolve in 6 months, then only consider lens exchange. And the principles of lens exchange are now replaced with a IOL which has low refractive index, material preferably not of acrylic, but which is unfortunately not possible. Edges should be round edges and not sharp edges. Optical diameter should be large, surface reflectivity low, more power to the anterior surface. And now there is American Academy is charged with developing a patient-reported outcome to be included in the future approval process for premium IOLs. So precise reasons why certain patients encounter negative dysphotopsia and others do not still remain a mystery. Reverse optic capture and piggyback IOL implantation in the sulcus are the most successful approaches for negative dysphotopsia. So take-home messages: surgeons need to know that dysphotopsia is a real and legitimate problem. Don't fool patients by saying all is well. Counsel all will be well in the near future. So dysphotopsias represent a failure of the current day cataract surgery and needs to be addressed by alterations of surgical methods, IOL designs, or both. If we are able to remove these haunting images from the field of vision of these patients, the smile will return back to the countenance of these distressed souls. Thank you, ladies and gentlemen, for your kind and patient.
Thank you very much, Dr. Bhalla, for a very elaborate and a very, very knowledgeable treatise on this particular problem. We'll have Dr. Chitra Ramamurthy. Dr. Bhalla, you can join us here, please. Dr. Chitra Ramamurthy. And I think it is the difficulty of negative dysphotopsia that is more difficult to address. But two things, as Dr. Bhalla said very well, is the reverse optic capture works extremely well when it is a very persistent thing, and the other that works very well also is sulcus placed piggyback IOL. So both these have worked extremely well, but the way to get out of the problem is for the placement of the haptics, which he alluded to, and let us try and place the haptics as horizontally as possible, 80 degrees, approximately as 20 degrees, and it is only when you have a toric IOL that you have to place it in wherever the toricity allows.